So I think that panel really brings out the problem is that the concussion is really not well defined. And I'm going to talk a little bit about what we're doing on subtypes, which is, I think, very exciting because we're identifying clinical conditions with objective measures that actually you can intervene with treatments and get the patients better. And I think, often we start with a possible biology and then work up to a clinical condition. I think in this case, we're doing it the correct way. We're starting from clinical types because it's heterogeneous, and then working down to the biology. Once we know the clinical types, you can go back to the biology. So my DNA is severe traumatic brain injury. With the Brain Trauma Foundation, we do evidence-based guidelines for taking care of people who are in coma after a head injury. And we've had, and those guidelines have led to a 50% drop in deaths from severe traumatic brain injury. So when the ambulance comes, the trauma centers, they all follow those guidelines. And a lot of it is telling people not to do dumb stuff that they used to do back in the 80s, which is hyperventilate, give steroids, and not really resuscitate patients. But when they started doing pharmaceutical drug trials, they all failed because we just said, it's coma. All patients are the same. They're in coma, they all have the same brain injury, where in fact they all had different brain injuries. And so applying one drug to this huge population led to a lot of drug failures. I'm afraid we're going to have the same problem in concussion unless we really find out what the biology is and define these different populations. Somebody gets hit in the head and gets a headache is not a way of diagnosing somebody. 90% of the public has headaches at one point or another. So we need to do better than that. So we're in sports medicine. I see the varsity athletes here. Angela is in the emergency room, and Jerry Grant is head of our pediatric center. And we see patients from outside at the Stanford Neuroscience Health Center. It's a very different practice. When I see patients here, there's a 2 or 3 month waiting list. When I see patients here, the varsity athletes, it's the next day or the same day. And very different. So you're seeing athletes with concussion, you're seeing immediately, and I'm seeing the lay public 2 months later. And what I see is a big difference in the symptoms. And the symptoms that come out at 2 or 3 months are a lot of mood disorders, anxiety, depression, and so on, because I've had these deficits for a long time. This is should my 8-year-old play football? I think we tackled that on the panel. There's a lot of angst in the public about concussion. This is Concussion Guidelines Step 1 that we published in Neurosurgery, and looking at best evidence, what's going on in concussion, and we basically came up with attention and balance disorders. But we came up with this general definition of concussion, which is a change in brain function, falling of force to the head, which you can have a loss of consciousness, but it's in awake individuals. And this is the one thing we really want is objective measures to really determine this. So what is the change in brain function? And this is Concussion Guidelines Step 1. We're about to publish, it's in Neurosurgery right now, Concussion Guidelines Step 2, which is evidence for subtype classification, which I'll be talking about. So you'll all get tested on this afterwards. So this is something we did with the Brain Trauma Task Force, a Brain Trauma Evidence-Based Consortium that was funded by the Department of Defense to classify traumatic brain injury from coma to concussion. And Portland State systems engineers came up, interviewed a lot of people in the space, and came up with a dynamic model. And if you go to dynamicsofconcussion.com, you can actually see this, and you can press on these little buttons and see what comes out at the end. But here's the injury, here's the impact, the effect on neurons and metabolism, inflammation, then the effect on sleep, cognitive faculties, and then mood. So it has has everything possible that can occur in concussion is in there. But how can we, really bind this together and come up with something that we can deal with? So this is the current management in most of the country. When I speak to my patients, they think your brain's on fire after a head injury. You should go in a dark room, wait for the fire to die down, and don't look at any screen because the fire will come back up again. And you'll get brain injury, you'll be at risk for another concussion or even death. there's one insurance company that had a video out for educating people about concussion. It showed a basketball player getting hit, and then the coach not recognizing she had a concussion, putting her back in the game. She got hit again, was down, was taken to the emergency room. As the story unfolds, she dies. And so I think most people, from that video anyway, that the second impact syndrome is critical. And I think that if somebody has a concussion, they shouldn't be put back into play because they can't pay attention, and they're at risk for injury. But I think I want to get back to this no exercise, because this is producing a lot of problems. It reminds me of the severe TBI guidelines, where they were giving steroids for traumatic brain injury and hyperventilating, and when we stopped that, people recovered a lot quicker. And there are a number of articles showing that early exercise promotes recovery. So I just want to say that from the get-go. Cardio exercise is key, and that varsity athletes, we wait 24 hours because of NCAA rules. But the next day, they're on stationary bike, and they're burning a lot of calories. There are the Letty or Buffalo protocol, where they have staged exercise based on symptoms, but this is really key. You've got to get people to exercise. So I'll get to that. So this is what we're focused on now. This really came out of the subtypes of concussion, came out of the teamwork from Pittsburgh. They had a big meeting back there in 2015, and they really asked physicians, what do you see in the clinic? What are the clinical phenotypes you see in concussion? And it came down to, and so we all came together. Let me just show you the authors first. So Josh Bloom, Dave Brody, Jim Chestnut, Jay Cluxon, Mickey Collins, me, Jerry Joya, Contos, Angela, Alan Sills is the CMO of the NFL, and Masa, who's here as well. So we all got together and we reviewed evidence, which I'll present to you in a minute, but we came up with these subtypes that are really coming out of this meeting, which is done in Pittsburgh. And there's 5 subtypes and 2 associated conditions. Jerry Joy and I wanted sleep to be one of the major subtypes, but we got voted down because for me personally, if I have somebody who doesn't have a sleep problem after concussion, immediately after concussion, I sometimes doubt if they had a concussion. You have to look for neck whiplash and things like that. So sleep is, for whatever the biology, sleep is affected. So. And these are not mutually exclusive. They occur together. So vestibular, oculomotor, cognitive, post-traumatic migraine, anxiety, mood, and then sleep, and then cervical is the neck whiplash. So I'm going to present, as we go through, just so you know, that I think that these 2, vestibular and oculomotor and cervical whiplash, are producing these symptoms. I think somebody asked me, well, if you had somebody had a head injury and they suddenly became anxious and depressed, but they didn't have any other vestibular, oculomotor, or cervical strain, would you call that a concussion? I would doubt that. I wouldn't call it a concussion. I think you need, and this is, I think, the next step is what you really need to make a definitive diagnosis. So we reviewed the literature, thousands of articles, and really, most of them are using symptom scores to define these conditions. So each one of the subtypes were scored based upon, and here we're just highlighting some of the ones that cross over in terms of the symptoms. But we really classified them according to the symptoms. And so the questions were: what's the prevalence of subtypes in concussion population compared with controls or baseline? What's the severity? What's the trajectories of those symptoms? And how do the subtypes cluster? So as you'd expect, and this is a review of this is coming out in Neurosurgery as a publication. First of all, in concussion, there's a high prevalence of these types compared to control populations. The largest one being headache, which is, we call them migraine because they're light and noise sensitivity. So the headache plus light or noise sensitivity, we call it a migraine. So they're very prevalent. They're all highly significant. So we're establishing the fact that in these subtypes, in concussion populations, there's a very high prevalence of these symptoms or these problems compared to a normal population. But however, they overlap. So somehow they overlap. This is being published in Neurosurgery, Concussion Guidelines, Step 2, Evidence for Concussion Subtypes. So here's a paper we came out with last year, which is on a different, it was actually a DoD-funded study where people were asking questions after concussion. And you can see there's different overlaps of these subtypes. So you may get all of them, you may get some of them, but you really have to measure all of them. So what's the current work is looking at the actual symptom scales that are used for concussion are really not designed to populate a subtype classification. There's not enough questions, for instance, in ocular motor and reading and things like that. And so we're designing a new symptom scale that can be used to populate the subtypes. So people would fill out the symptoms, and then automatically you'd see how much are ocular motor, vestibular, migraine, depression, and so on, sleep. And then we're also looking for trajectory recoveries. Like if somebody has just vestibular, do they recover longer? Do they take longer to recover compared to somebody who just has ocular motor? Or if they have two of those, how do they recover? And then finally, once these groups are clustered and looked at, then we should look at the biology, right? Somebody has vestibular and migraine, but not, say, anxiety, mood problems. Do they have a different biology than somebody with ocular motor and cognitive problems? So they're prevalent. Headache and migraine and mood disorders are the highest. And I would say that a lot of these populations, you have to look at whether they're coming from a clinic or they're coming from athletes. They're not mutually exclusive. 1 out of 4 have all of them. So I have patients who have all the subtypes. But it's important to identify them and see what they are so that we can correct them. So I'm going to present what I think is the biology. I like to stick my head out and say, I think this is what the biology is going on. So I look at concussion as a disorientation disorder, and it's a problem with prediction. And I think that these deficits, the prediction deficits, cause a disorientation that you can measure with ocular motor vestibular measures. And that because you have that problem, you get migraine headaches, anxiety, mood disorders, and cognitive problems. So a lot of people think the cognitive problem is primary injury. I would say it's a problem with prediction. And so what is prediction? So by the time somebody sees that ball, it's actually gone. And so if you actually try to hit it, you'd never be able to hit it. So you have to predict to be able to hit the ball. And so you need spatial, you need to know where it is and when it is to be able to interact and hit the ball. And so we wrote about this over 10 years ago. And this is the circuit responsible for attention. I would say prefrontal cortex, parietal lobe, and cerebellum generally involved in attention networks. And they're really predicting. So spatial prediction, timing prediction, and then I want to hit the ball. So here we wrote this paper. We have a lot of references in biology about that. But it really, that there may be a timing deficiency in traumatic brain injury originating from the cerebellum. So I like to tell my patients your brain's in the past. Everything you sense has already happened. So it's actually impossible to be in the present. I know the mindfulness people will already get upset with us, but unfortunately, if you have a neuron, you're in the past. It takes time to process information, so it's actually impossible to be in the present. So the only way to interact in the present is to be in the future. And so your brain is really geared up for it. If you look at the number of neurons in the brain, we'll round it up to 100 billion. 80 billion are in the cerebellum, the granule cells. And I would propose that they're predicting the future if you look at the circuitry. So you have to predict the future to interact in the present, which nobody really senses in the immediate moment, to experience the past. And this is the problem we have with concussion, is the prediction part. So how do we measure it? How can we measure prediction? Well, we need something that moves. And the eyeballs move because you've got to foveate so all the information you really want to pay attention to has to land in this little area. So if you put your thumb out and you look at it, that's the area you can foveate. Everything else around is a blur. And when you start moving your thumb, you have to move your eyes to visualize your thumb. That's not so much your eyes, it's your brain. Your brain has to predict and move the eyes. So even though we're using vision or ocular motor, it's really brain-eye interaction. So you need to move the eyes to keep the image in the fovea. Prediction needed to maintain the focus. And by the way, it only happens in humans and higher primates. Your dog or cat doesn't have smooth pursuit. They don't do this. They have saccadic eye movements. Unless you watch Jurassic Park with the dinosaurs, those eyes move smoothly and everyone gets terrified. But so you need spatial and temporal orientation of self to the world. And I'm going to get into that whole thing of orienting to yourself and orienting to the outside world. Both require prediction. Poor prediction results in variable synchronization. You can measure that with eye tracking. So if you look at smooth pursuit or eye tracking, they involve multiple systems. There's a whole brainstem system where oculomotor and vestibular nuclei are localized, but you also get many areas in the cortex. So I like to look at the cortical areas as really orienting to the external world, whereas the brainstem and thalamus are orienting to the internal world. What's this? This internal world is when you're moving with respect to something and you got to orient to it. It's giving predictive signals. The other one is the outside world's moving and you're still, and that's more cortical. So we have a bunch of tests that we do. We have smooth pursuit, which I just described. The outside world's moving, you're still. VOR is the outside world still and you're moving, and then VR cancellation is both worlds are moving. So these are really easy tests to test prediction. So if you go to the optometrist to measure your vision, or kids in school, or you go to the DMV, they do this. Read the chart, right? But the world's not really like that. The world is actually moving. So this is what they should really be testing. So the car's not sitting in the parking lot with you reading the license plate. It's moving. And so the prediction part is not so much vision. It's your brain predicting in real time so you can synchronize and process information. So we've done a lot of work looking at cerebellar connections to brainstem and prefrontal cortex using MRI. And what we're seeing is that these connections here, and by the way, this is the superior cerebellar peduncle. This is the outflow tract of the cerebellum that sends a predictive signal to oculomotor, vestibular, and prefrontal cortex. This is basically a feed-forward inhibitory timing, holding back motor and cognitive function to synchronize with sensory information. I know I just said a lot, but so this connection is right here. You can see that it goes to vestibular nuclei, so VOR, and up to thalamus, up to the prefrontal cortex, the frontal eye fields to do smooth pursuit. So it's an ideal area. This area here is actually, we know in severe TBI, the dorsal midbrain is an area where diffuse axonal injury occurs. So it's very active. There are lots of circuits from here, from cerebellum, the prefrontal cortex, motor areas, and these are the areas where you have diffuse axonal injury. So you can see how you can get a heterogeneity in concussion by where you're getting the shear injury. This is a paper work we did with UC San Francisco looking at MRI of athletes showing that there's a decreased integrity of the white matter tracts in the superior cerebellar peduncle and the middle cerebellar peduncle. And we also had a paper a while ago showing a correlation with eye tracking with the superior cerebellar peduncle white matter damage, and also correlates with the genia of the corpus callosum and the anterior corona radiata, that's white matter tract up here in the prefrontal cortex. But the best correlation was with superior cerebellar peduncle. This is the eye tracking that we use. This is a normal patient, normal subject, and you can see there's a dot going around a circle, and you can synchronize very well with that. Here's the dot with all the eye movements around it, and we measure the variance in this direction, which is the timing prediction, and this is spatial prediction. What we see often in concussion is this, and by the way, there are patients who have a normal signal, but they maybe have trouble with VOR. So you can have heterogeneity in the presentation. But what we see is that the eyes jump ahead. I thought that the concussion patient would just be slow. They'd be behind. They'd have poor prediction, and they'd be lagging behind the target. Well, actually, they're ahead. So what's really going on there is that you're breaking the future to be in the present, to be aware of the past. So you have this inhibitory control in the prefrontal cortex and motor areas, and it's released just when the sensory information comes in so you can synchronize. And those breaks are the ones that get damaged, either it's from the superior cerebellar peduncle or the white matter in prefrontal cortex that cause you to become disinhibited. And we know that concussion patients and people with severe TBI are disinhibited. They're cranky, irritable, they have poor judgments, they don't feel like themselves. It's because of the disinhibition part of it. The other part is the vestibular part, and the Pittsburgh group has done a terrific job with the VOMS, which is a nice test for testing for symptoms that are induced by doing a predictive task, like watching your finger go back and forth, or the VOR going like this. And they found that 61% of patients who came with a headache, with a diagnosis of concussion, had symptoms when they were induced. So these are cerebellar connections to the vestibular nuclei that, again, come off of the middle cerebellar peduncle and the superior cerebellar peduncle. And so the thinking is that there's some shearing going on there, and that's responsible. The actual nuclei, whether it's oculomotor or vestibular, works. You can have full eye movements in concussion patients, but when you have something that's predictive and you got to follow it very closely, then you have problems. That's where the brain comes involved. So I think it's a predictive signal that's involved, not the actual motor function. This is from DIVBIC, the Defense Veterans Brain Injury Center. They have a great artist there, and they actually put together the VOMS, how you do it for the military. I think it's a terrific test if you don't have anything, just to elicit symptoms, just so you know. Probably about, depends on population, up to 20% of the population can have symptoms doing some of these vestibular exercises. So it's important to do a baseline if you can do it. But I find it to be very easy to do. You know, you put your finger back and forth, you have them move back and forth, you can do VORX. And nice way, you can go on the web and you can see YouTube videos of how they do this. So let's do keys to recovery. Obviously, cardio exercise is number one. I'll show you some data on that. Sleep, sleep is affected primarily. I find that and I tell my patients that as they recover from the concussion, they'll see their sleep improve. The patients have trouble going to sleep. They have very light sleep. They wake up in the morning, they feel tired, they take long naps. I tell them, do not take a nap longer than 30 minutes. And if possible, don't take a nap. I think Nora Simpson's going to be talking about sleep a little bit later. But I find these patients have very light sleep. Even though they sleep 8 hours or 10 hours, they feel tired afterwards. But as they recover, the sleep recovers. So, but I think sleep hygiene is very important. You should tell your patients not to sleep 2 or 3 hours in the afternoon, which a lot of people are trying to catch up on their sleep, and they try to do that, and it impairs their sleep at night. Again, the expectation is very important. Tell your patients that they will get better. You found out what's wrong with them. You're correcting it. You have active interventions, which we'll talk about. And I think that goes to making a better recovery. So cardio exercise, I can't tell you how important it is. And so we put people usually on stationary bikes because they can have vestibular symptoms. Not that the vestibular symptoms are bad, it's just they won't finish the cardio. So with a stationary bike, you can get exercise and not move the head. And so you don't get symptoms. And so it's a great way, all the athletes the next day go on a stationary bike and get a lot of cardio. So there's 3 articles here showing that early cardio exercise promotes recovery, both in kids and adults. The training we do for ocular motor, we do smooth pursuit training, convergence, saccades, and reading exercises. Vestibular is VOR, so they have problems doing this. What's the treatment? It's doing this. And so it's kind of like you're retraining the cerebellum. The cerebellum is a learning machine, and so you're really retraining it. And so balance is important as well. Cervical is very important, neck whiplash. The superior oblique capitis, this little muscle up here in the suboccipital triangle, is the nasty muscle that gets stretched. It has a lot of afferents into the brain, and you can get cervical ocular reflex impairment. You can get feeling of fogginess, fullness in the ears, fullness in the face. A lot of people come in and say, I feel this headache behind my eyes, it's behind my occiput, and I feel foggy. And all they have is a neck whiplash. So neck whiplash can produce a lot of symptoms, and you got to identify it. And so doing a lot of range of motion, and I find that the physical therapists, there's some that are specialized in the neck, and they do a really good job of getting this sorted out. If you don't sort this out, it could be a long-term problem. A lot of patients taking a long time to recover have a cervical whiplash. Migraines, again, some of them have prior history of migraines. I always say patients bring baggage to a concussion. They're usually prior history of migraine, especially on their mother's side of the family. Sleep apnea is a big one. And a lot of them had anxiety and depression before, but they were exercising. And then their doctor told them, don't exercise. And so they became more anxious and depressed. But it's a major part of a practice that sees patients months after their concussion. And you have to address it. So that's what you so we call it the Concussion and Brain Performance Center because we're not only doing the concussion diagnosis and treatment, but we're also identifying problems they had before their concussion. And I think focusing on that will help them to recover. So a lot of these patients may have prior sleep problems, migraine history, or anxiety, depression. You have to target those or else they're not going to get better. So I want to thank Hamid Moghadam for supporting our center. He's been terrific. We're opening up the Vision Performance Lab here in Stanford Sports Medicine, and we're going to have a neurooptometrist there training people with Smooth Pursuit and VOR, and we have lots of different gizmos to do that. This is the AR from Magic Leap that we're going to be using as well in there. And so it's going to be a state-of-the-art facility for training up people. So we're finding about 5 to 10% of the athletes have oculomotor impairments. And it's very interesting. They're in certain quadrants. So you can actually pick out people who are on the left side can't predict well. And they've been avoiding that area. So they've been sort of developmental. And people will pick a sport where they don't have to interact in this lower left area. They'll turn their bodies away from it. And if you actually try and stimulate them in that area, they feel very anxious. And so I think there's a lot of progress and work that needs to be done in this area in terms of prediction, both in spatial and in timing prediction. And you can get people with quadrant problems just at baseline, just developmental. So some of the things I'm working with right now is kids that were with dyslexia and ADHD. And by the way, one of the big causes of concussion are kids with ADHD. And they have a certain kind of eye movement that's different from what we see in concussions. A lot more variance around the mean. And we published papers showing that when they get on medication, their eye tracking improves. So I think that identifying problems at baseline will prevent injuries. And that's one of the main purposes of this center, is to focus on brain performance. Because if we can correct the problem at baseline, we'll reduce the injuries. We have a paper coming out showing that eye tracking impairments is not what you saw in the concussion patients, more in the radial direction. If they have eye tracking problems at baseline, a 2.5-fold increase for risk for concussions. So it's at the same level. So the one just above that is a prior history of concussions, and then there's the eye tracking problem, and then ADHD is the third one that raises the risk of having a concussion. So with that, I'll stop. 1 minute. Okay, any questions? Yeah.
Are there, you talked about baseline, so are there actual tests that athletes can do before getting into their sport or their season of sports so that they
Yeah.
have a baseline? My kids are in freestyle skiing, and at the beginning of putting them in that, they told me that they were going to do this baseline testing, and then it never happened.
Mm.
And so part of the reason I'm here, but I just wanted to know
Yeah.
how do you do that?
So one of the most popular tests is IMPACT, which is a neurocognitive test, and it's been used since the 90s. Joe Maroon and the Pittsburgh people developed it a long time ago, and they're way ahead of their time. I think now that there's other tests as well that you can use. So in the Pac-12, we do baseline eye tracking, SCAT-5. There's an NCAA CARE consortium package of things that need to be done with all the athletes that they recommend. It's called CARE 2.0, and they have basically it's neurocognitive testing, SCAT-5, and then the options of doing oculomotor and oculovestibular testing. So I would encourage them to do baseline oculomotor and oculovestibular testing at baseline. You can go to, so a lot of places, if you go, so the neurooptometrist, this area is being sort of populated by different people. Usually sports medicine clinics will do baselines, or a neurologist will do baselines. or you'll find some of the neurooptometrists will do them. It's a variety of people would do these kind of tests, and they'll store the baseline. If your kid gets a concussion, you come back. So for most organized sports, they usually have a doctor they refer to, who they do the baselines in and then come back to compare that.
Is it reproducible? Like, do you have to run to the same person that did the testing or somebody else?
You have to look at the retest reliability of some of the tests. They can be a little bit off, and so we talked about it at the panel, that people can game some of them and things like that. But, you know, I think, you know, at the end of the day, the baseline, I look as a surveillance, not a snapshot of before. It's like, do you have a problem? Before you go play sports, if you can't, you know, if you've got vestibular balance problems, for instance, maybe you shouldn't be doing freestyle skiing, you know. Yeah. Yeah, go ahead.
Yeah, so you got a little cluster of eye doctors over here that are like so excited we're about ready to jump off our seats.
Okay.
Because we've been doing this for years. So just a supportive comment, the natural progression from the Keen DVIC test we've been doing for 40 plus years,
Yeah.
that it has actually become more standardized and more objective and accessible. The question is, you tend to ignore convergence, which we've always found is also a painful convergence, a very diagnostic.
Yeah, I didn't mean to ignore it. I mean, I think you should measure convergence, yeah, yeah.
But it's a little more objective, it's
Right.
not objective, maybe
Yeah.
it's more subjective, so
Yeah.
pursuit movements you can't cheat on, so.
Yeah. No, you should measure convergence. Yeah, sorry I didn't bring that up. So I would consider that part of ocular motor, convergence, smooth pursuit, and looking at saccades as well. I mean, all those things. Eventually, I think what's going to happen is, because of the heterogeneity of the forces and how they injure the brain, I think you're going to get groups of people that are going to cluster. They're going to have maybe convergence problems with some vestibular balance and migraine, and then another group over here is going to have smooth pursuit and something like that. And then you're going to look at the biology and find, wow, those guys had shear injury in this pathway and this pathway, and these people take 3 months to recover, and these take 1 month to recover. But if we give this drug or exercise them or do some kind of therapy, they'll improve. But I think we have to start somewhere, and I think that it's really I call it disorientation. I mean, we're just using the eyes to measure prediction. It's not an actual eyeball vision problem. It's the brain controlling it. And the wonderful thing about the eyes, you can do lots of things. You know, VOR, smooth pursuit, convergence. I mean, you try the ears. You can't. The ears don't do much. They don't move very well. Yeah. I mean, we have. Yeah, I think we'll have to. I'll take questions later if you'd like.
Thank you very much.